So we've already talked about the use of NSAIDs in lupus for fevers, headache, aching, and even serositis. The treatment algorithm is such that for those with constitutional symptoms of fatigue and aching, we can use steroids, hydroxychloroquine, or a combination, and sometimes we have to use azathioprine, methotrexate, or mycophenolate. We would rarely need something stronger. With widespread cutaneous disease, animalarials are the first line, along with corticosteroids. Systemic drugs rarely have to be used for cutaneous disease, but mycophenolate, cyclosporin A, azathioprine, methotrexate, and belimumab can be used. And for those who have digital or cutaneous vasculitis, we may have to be more aggressive with immune suppressive regimens, sometimes being more quick to use methotrexate, mycophenolate, Cellcept, or even intravenous cyclophosphamide. Whereas 80% of all rheumatoid arthritis patients in the United States are taking methotrexate, studies in lupus are limited, but it appears to be effective, and about 20% of all lupus patients in the United States are taking methotrexate at any given moment. It does tend to lower the SLEDAI score and have an effect on being steroid sparing. This drug is well known, appears to be generally quite safe, and is taken weekly. For those with more serious disease, mycophenolate and azathioprine can be used. We generally restrict mycophenolate to more renal or pulmonary disease, whereas azathioprine can be used in non-organ threatening lupus for just about any manifestation. Both are steroid sparing. Then there's a group that we call niche therapies that are only used for specific organs or areas of involvement. For cutaneous disease, we might use retinoids, some of the anti-leprosy drugs such as Dapsone, some of the topical calcineurins such as pimecrolimus or tacrolimus. For low platelet counts, we might use a hormone like an androgen such as danazol, intravenous immunoglobulin. Rituxan appears to be particularly effective, as is splenectomy. For those with central nervous system disease, if it's very serious, we might want to use intrathecal methotrexate, cyclophosphamide, or rituximab. For those who have had thromboembolic events, blood thinners. For those who have vasomotor instability and dysautonomia, calcium channel blockers, and vasodilators such as phosphodiesterase inhibitors, especially if one has pulmonary hypertension. Then we add the endothelin inhibitors and prostaglandins.